Hi, so today we're going to be talking about how to do scalp blocks for an awake craniotomy. So I'm just going to take you through what you need to get prepped prior to doing your scalp block. So this is a sterile procedure. What we typically have are your sterile gloves. So I've got a size 6 gloves right here. We also need to have two 10 cc syringes. So usually I use 10 cc's for one side and 10 cc's for the other side. And then some sort of needle. So we have here a 25 gauge, so these are good. So one for each. We're also going to need prep. So we would have prep of some sort, either in here or prep sticks, or these are fine too, to prep before doing the blocks. So we're just going to go over the solutions that we would use for scalp blocks for either awake or asleep craniotomies. So typically we use 0.5% bupivacaine with epinephrine, so that's this solution right here. And then you would also use 0.25% bupivacaine with epinephrine for the non-operative side. The other way of doing it would be to do a solution that is 1/3 2% lidocaine, so typically use this, and the other 2/3 would be the 0.5% bupivacaine with epinephrine.
So when we start doing blocks for craniotomy, it's important to recognize the 5 major nerves that we block. The first one is the supraorbital nerve that can be found about 1 centimeter superior to the supraorbital notch, which is near the eyebrow. So you would locate that, palpate, and it's just about 1 centimeter above, usually by the line of the eyebrow hair. Medial to this, kind of where the eyebrow starts, you can find the supratrochlear nerve, which we will block as well. The next nerve is the zygomatical temporal nerve, and that can be found by finding the junction of the zygomatic and temporal bone. Often it's about 1 inch to 0.6 of an inch lateral to the lateral epicanthal fold, and you can find that just by palpating. We also have the temporal auricular nerve, and that can be found about 1 centimeter to 1.5 centimeters anterior to the tragus of the ear. And when looking for this nerve, you want to make sure that you find your superficial temporal artery. You can enter either medial or, anterior or posterior to it, but you want to make sure you don't enter the artery, and then the nerve is often located deep, the nerve is located deep to the artery. Finally, in the back, we normally block the greater and the lesser occipital nerve. This can be found by finding the greater occipital protuberance and the mastoid process, and using the 1/3 2/3 location. When blocking the greater occipital nerve, you want to also make sure that you palpate the occipital artery to make sure that, again, you are not going through the artery. All right, so we're going to be starting with the supraorbital nerve. Usually when I'm doing my blocks, I start on the operative side first to allow more soak time. Prior to beginning, I prepped the area. Obviously this is a mannequin, so I won't prep it in real life. Then I take my solution and I feel the eyebrow for this supraorbital notch. Once I feel this, I go about 1 centimeter above, almost kind of where the hairline of the eyebrow is, and I insert my needle perpendicularly until I hit bone. Once I hit the bone, I pull back ever so slightly and I inject about 0.5 cc of my solution. After that, I kind of I pull back further and I fan medial to lateral and do a more superficial injection of another 0.5 cc. At the same time, while I have the needle in here, I do my supratrochlear nerve. That can be found more medially, kind of at the hairline where the eyebrow starts. So at that point, with the same needle insertion, I just go very superficially until I kind of get to that supratrochlear nerve, and I inject another cc. Once that's done, I remove my needle put it back in my sterile field. And I'll often use gauze to just massage the area, which ensures that the nerve block works better.
So the next nerve that we're going to block is the zygomatical temporal. So as we were mentioning earlier, this is usually found 1 inch lateral to the lateral epicanthal fold. So right about this area. So the first thing we're going to do is we're going to clean the area. So we'll make it nice and sterile. And then what we're going to do is take our solution. We'll mark where we're going to go. So for this one, I usually go perpendicular to the skin, insert. You're usually able to hit bone. Once you do, I pull back a little bit, aspirate, and then inject. I usually inject about 2 cc's of my solution at this spot. And once that's done, we would get our gauze, which I have here. And again, just massage the area so that the solution sort of penetrates through the tissues and gets to the nerve. Also, sometimes these bleed and the patient is awake, so it's just nicer to make sure you have some gauze available. After that nerve is done, we'll do the auriculotemporal nerve. So this nerve, as we were saying before, is located just more medial to the tragus of the ear. So this one's important for several reasons. One, the artery is right here, so we have to make sure we don't inject into the artery. And also, if injected in the inaccurate location, you can get a facial drip on this side, which isn't great during the awake craniotomy and is a little bit distressing to the patient. So it's an important one. And what I typically do is I feel for the temporal artery here. And once I feel it, I go just above with my needle. Sorry, I should clean that first. So we'll clean it. So I feel for my artery, I go just above and I inject down, trying to go underneath the artery because that is where the nerve is. And then I always aspirate here to make sure there's no blood because you are very near to the artery. And then I would inject 2 cc's again. And once that's done, again, I take my gauze and I just massage that area.
Great, so the next 2 nerves we'll be blocking are the greater and lesser occipital nerves. To do this, I clean the area between the mastoid process and the greater occipital protuberance really well. Sometimes the patient still has hair in this location, so you just kind of have to work around the hair, and you need to rotate their head if they are asleep, and if they're awake, you will get them to turn their head. Okay, I have then I find with my fingers the greater occipital protuberance and the mastoid process. And I kind of draw an imaginary line between these 2 sites, and I locate the 1/3 and the 2/3 portion. For the lesser occipital nerve, what I usually do is I enter perpendicular to the skin until I hit bone. Once I hit bone, I pull back about 1 or 2 millimeters and I inject 1 centimeter after I aspirate a negative, kind of at the level of periosteum. Once that's done, I kind of pull back a little bit, and as sometimes the nerve may be in a different position in some patients, I kind of fan back and forth and do another ½ cc to the left and another ½ cc to the right, just to ensure that I get good coverage. I then pull back and massage that in to ensure that I've got good nerve coverage. And sometimes it does bleed as well because the back of the head is very vascular, so also to provide hemostasis. After that, I kind of go back to my second landmark, which is the 2/3 position on that line between the mastoid process and the greater occipital protuberance. And here I'm looking to feel the occipital artery, because because you do not want to inject this artery. Once I find it, I kind of inject either medial or lateral to it, usually more medial. At this point, I enter perpendicular to the skin. I hit bone, pull back just to the level of slightly past periosteum. Very important to withdraw. Make sure there's a negative aspiration, and then I inject about 1 cc of my solution as I slowly pull my needle back. And again, I just make sure, without hitting artery, that I inject a little bit more superficially. And at that point, I would massage that in. Sometimes if I have extra solution left after doing all my nerve blocks, and I've calculated the patient's toxic dose, and I know I do have a little bit left, I sometimes can even do a superficial ring block that connects the greater occipital to lesser occipital nerve at the level of the skin, just a superficial line there. I may inject about my last remaining 1 cc to connect those points and just massage it in. So timing is very important for these blocks. They do need some soak time. So when doing blocks for an awake cranie, I tend to do the blocks as the first thing I do before the art line or the IVs go in to allow the most soak time possible. If I'm doing blocks for an asleep cranie, then I tend to actually put the art line in, put the patient to sleep, intubate, put my second IV, and then kind of in that time where nursing is putting in the Foley, I may at that point do my blocks for my asleep cranie.
So it's important when you're doing the scalp block to make sure that you know the toxic dose for each patient. So generally how you do that is you use the patient's ideal body weight. So you would take their height in centimeters minus 100, and that would be roughly what the patient's ideal body weight is. And then you would calculate it based on the solution that you're using. So if you're using the combination of lidocaine bupivacaine, or if you're using just plain bupivacaine. Something to keep in mind, and what I typically do, so if you use 0.5% on the operative side and 0.25% on the non-operative side, and you stick to just the 20 cc's, then you won't go over your toxic dose for most patients. You still should calculate it though. And then that is useful because if you stay under with the 20 cc's, if then the surgeon goes to do the case and the patient is complaining of pain, there is some room for the surgeon to supplement in the areas that are painful. So that would be the next step. If the surgeon was operating and there was some pain, would just be to ask him to supplement with a little bit more local anesthetic.